So today I'm going to talk about the critical appraisal station and if you're asked to critically appraise a paper in an interview. So kind of when thinking of evidence, we need to think about, the value of that evidence as well. So these are all the different types of evidence there are and things that you may be asked to look at during an interview. So the strongest type of evidence are meta-analyses, and the lowest are kind of case reports or opinion letters. And I will today focus on randomized control trials, but that's because it's probably the most likely that will come up in an interview, and also the most common kind of critical appraisal that you'll be asked for in journal clubs and in presentations that you might have to do further down in your career. But generally speaking, you could potentially be asked about any of these things during your interview. And it is good to be familiar with any of them as well. So why do we actually need to critically appraise a paper? So we conduct evidence-based medicine. So we need to decide when a paper comes out whether or not that evidence should change our practice. So that kind of comes into validity. So validity is whether or not something is true. So if it has internal validity, it means that the study is true, or the study outcomes are true for the population that was studied, so for the study population. And if it has external validity, it is also valid, so true for the external study population. So any people outside of that would be similar to this population studied outside in the real world. So when something is internally valid, we then need to think, is it externally valid? And if it is, then will it actually change your practice? Is this something that is going to change how we treat people? So in an interview situation, again, they might ask you about all types of studies, but they usually, the kind of critical appraisal station that I've had at interviews, both of my interviews for the SFP, have been just getting results, tables, abstracts, or pieces of information that I've not seen before during that interview. But some people might get it at the day of the interview to look at beforehand, or they could even ask you about a paper that you've read recently. And then usually they will ask you to summarize that. And that should take no longer than 2 minutes. And if they ask you questions, those are typically kind of about strengths and weaknesses of the data that presented or the study that they've presented to you, or any biases that you can think of, whether or not you want to comment on the methods or if you would have changed the methods at all, as well as kind of statistical terms, as well as validity. So whether or not it would change your practice. So today I'm going to go through kind of the structure that I use and how I critically appraise a paper. So that kind of starts with core details, which is PICO, then the main findings, then I go through strengths and limitations, then whether or not it's valid, and finally kind of I usually comment on the ethics if I've not done that beforehand. But after kind of going through my little structure and my little hints and like that I can give you really, I'll just critically appraise a paper and go through a paper together with you. I know that I think that the paper was already posted on the Facebook page, but it's not a problem at all if you've not read it, because you should get a feel for the paper as we go through it anyway. And of course, feel free to have a look at the paper afterwards and, maybe you completely disagree with the things that I've said. And that's the kind of beauty of critical appraisal, because everyone is going to have their own opinions on it. Right, so kind of starting, so core details to me is PICO, as well as kind of the extras. So I usually start off with one sentence on the population, the intervention, the comparator, and the outcomes. So the population is who was in the study, the inclusion and exclusion criteria, what the sample size was, and the intervention is then going to be, what was done differently in that study. Was it a drug? Was it a program? The comparator is, or should be, usual care, but in some studies that might not be the case. And that's just, for example, if it's a retrospective cohort study, you're not going to have a comparator or control, you'll just have an intervention group. And then looking at outcomes, kind of what were the primary and secondary outcomes of the study. Sometimes, though, I would just say the primary outcome in that sentence rather than the secondary outcomes, because there can be a very long list of outcomes. And usually what I also include in the introductory sentence is the setting, the time frame, and the study type. So kind of, I'll go through an example of how I would present that when we're actually critically appraising the paper, but that's kind of the things that I usually speak about. So then kind of moving on to main findings, things that you need to be aware of that here is that you want to be as concise as possible. So you want to tell the interviewer as quickly as possible what the study actually found out. And a lot of times that's quite easy because it's going to be your primary outcome, but you need to make sure that you use the right statistical terms. So you might be asked about confidence intervals or p-values and what that actually means. And those are the particular ones that I would focus on if I were you, but also just be aware of kind of hazard ratios, odds ratios, number needed to treat, as well as like relative risk. So confidence intervals, I'm sure you're already aware of, but they're basically the kind of a scale of numbers that suggest that this is the effect that a certain thing had in a 95% confidence interval around the estimate of the study. So let's say if I had a study comparing a mystery drug to a placebo, and that mystery drug reduced mortality by 25%, and the confidence interval, the 95% confidence interval was from 15 to 35%, then we could say we are 95% confident that this drug reduces mortality by 15 to 35%. And that's based on the estimate of 25% in this study. And p-values are very, very similar to that. So they are kind of the likelihood that what we have discovered has occurred by chance. So the difference discovered has occurred by chance. So if a p-value is less than 0.05, that suggests that the risk of that result happening by chance was less than 5%. And that is usually considered statistically significant in any scientific paper worldwide. And it's just an arbitrary cutoff that you need to be aware of. So you just need to be familiar with those two terms and just comfortably mention them, and also be comfortable with defining them if you're asked to. And then just be aware that, you know, hazard ratios, odds ratios, number needed to treat, as well as relative risk, and any outcome that you're going to come across in these interviews is also going to have confidence intervals and p-values. So even if you have no clue what you're actually talking about, you'll be able to mention what the confidence interval of that outcome means or what that p-value means. Then I move on to strengths and limitations. So these are usually things that impact the validity, so impact whether or not that study is true or whether the outcome is true. So I like to think of it in the same way as the PICO initially. So thinking about the population, you know, looking at the study design, were they blinded, were they randomized? Is there a risk of kind of confounding bias or selection bias that's there? You can also look at inclusion and exclusion criteria, or whether or not the study population is actually representative of the population that they're wanting to have this impact on. And then I kind of look at the intervention. You know, what were the strengths and limitations there? Did they consider dropouts? Were there a lot of people lost to follow-up? You can think about intention to treat analyses and whether or not they were conducted there. And also, is that intervention possible in the real world? So, for example, if it's a program, do people in real life actually have the time, or are there the resources available to do that intervention in the real world? Or would people just not be compliant with the intervention outside of the study? So that's also something to consider. And for the control group, you just need to make sure that what they compared their intervention to was real world management. So if that is not the case, then it's not going to be externally valid at all. And that's going to be a massive limitation. And then for outcomes, you can also look at whether or not the outcomes were designed to be relevant to both patients and clinicians. So some studies that I've read before have been looking at kind of CRP and whether or not it's increased or decreased from a drug. And that might not really be a very robust outcome, just because it doesn't actually matter to the patient or to the clinician whether or not their CRP is 20 or 200. What really matters is whether or not they're going to have good outcomes, whether or not they're going to die within 90 days. So that's going to be considered more robust. Also considering outcomes, you need to think about the analysis. So that, whether or not the analysis was appropriate. Did they use hazard ratios even though they should have used odds ratios, and so on. So those are just the ways that I think about strengths and limitations. This is a kind of a table to illustrate that a bit more. So I'm not going to go through all of the table, but basically these are the things that I look at for a population. For example, the type of study, the demographics, the blinding, and then depending on those things, I'll ask certain questions. So who is the study looking at? Is there blinding? Who was blinded? And that's going to give you some information about selection bias, confounding bias, whether there was detection bias, or whether or not it's externally valid as well. So that's just something to have a look at a bit more in detail when you've got some free time. And I'll do the same thing for, the intervention comparator as well as the outcomes. So again, different things in the outcome section that you can look at, different questions that you can ask, and what that actual meaning is, what potential strengths and limitations that may have. So here, for example, be familiar with data fishing or data mining, as it's called, and also p-hacking. So just know a couple of terms that you might be able to look for from very, very basic tables and basic descriptions of studies that you might be able to get in interviews. And then finally, I look at validity. So once you have done all of those things, you can then kind of comment on whether or not something is internally and externally valid. So the first thing that you need to comment on is whether or not it's internally valid. So is there truth in the study? So does it represent the outcomes of the population that was actually studied? And things that will affect internal validity will be the strengths and limitations that we talked about. So if there was a significant confounding factor, then actually what the effect that might have been measured wouldn't actually be true for that population. So it would not be internally valid. And then external validity is something that you can ask once you've established that the study is true in itself. So once there's internal validity, you can look at external validity. So do the results that have been found also apply to similar patients in a different setting? So in my clinical practice, for example. And again, things that will be dependent on that are going to be similar to the strengths and limitations. So whether or not the study was actually comparing, whether the intervention was useful, whether or not the intervention was something that can be conducted in the external world, and also whether or not the comparator was something that is being used in the real world. And then my final sentence, if I've not mentioned it before, oftentimes I would mention it in the strengths and limitations just to flesh things out. But the final thing that you can think about is ethics. So for ethics, I always think about the researcher. So do they have ulterior motives? Who were they funded by? And I think about kind of PICO as well. So the population, was there informed consent? Were they treated anonymously, and was there confidentiality? And then thinking about the intervention, was the intervention appropriate? Was there a right to withdraw? And also a very important question is equipoise. So equipoise is the necessity that there has to be, that people or clinicians have to not be 100% sure that there's one best way to treat the thing that is being studied. So if I knew that this drug is the best way to treat anyone, then there's no need for this trial. So it would be an unethical trial. There would not be any equipoise. And then finally, I look at kind of the ethics and the outcomes as well. So would the outcomes make a difference to clinical practice? Because if they don't, then there was no need to conduct this trial, and there was no need to take this patient's information or to change their usual care either. Right, so now let's critically appraise a paper. So I've prepared a paper. I've had a look at. Second. There it is. So this is the approx study, and again, have a read through it in your own time. I'm not going to go through the entire paper with you. I'm just going to pick out bits that I have noticed when reading a paper, and I'll just go through the way that I would usually read a paper. So the first thing that you can notice is, where was it published? So this was in the New England Journal of Medicine, which generally has quite is quite well known, and you can see kind of that it was published by a network of people, and we can read the title. So it's hydrocortisone plus fludrocortisone for adults with septic shock. The first thing that I do when I'm looking at a paper is I'll go through the abstract, and that's just because it's easy, it's quick. So looking at kind of the background, they are defining septic shock, and then they hypothesize that the therapy with hydrocortisone plus fludrocortisone, or with dropped recagen alpha, which is actually activated protein C. So that's not necessarily something that you need to know in order to critically appraise this trial. But it's just easier to say is activated protein C, which can modulate the host response, would improve clinical outcomes of patients with septic shock. So this sentence already kind of suggests that there was equipoise, and that they hypothesized this. They thought that this could potentially have a benefit. And also it gives us some information that there was a third drug that's not mentioned in the title. Then kind of going on to methods. In this multi-center, double-blind, randomized control trial with a 2x2 factorial design. So just be aware of a couple of design types for randomized control trials. So 2x2 factorial design just means that they looked at 4 different groups. So a 2x2 square in a way. So one group will have had the activated protein C and a placebo. One group will have had 2 placebos. Another group will have had the steroids plus the placebo, and the final group would have had the protein C and the steroids. So the benefit of a 2x2 factorial design is just that you can look at 2 different drugs and 2 different effects at the same time, but actually need a lower power for these patients or for the study. So that's the one that they used. We evaluated the effect of hydrocortisone plus fludrocortisone therapy, activated protein C, the combination of the 3 drugs, or their respective placebos. And the primary outcome was 90-day all-cause mortality. And then they also include the secondary outcomes that they looked at. So that was ICU discharge, hospital discharge at day 28 and day 180, and the number alive and free off of vasopressors, mechanical ventilation, or organ failure. And then this is actually quite interesting. So the activated protein C was then withdrawn from the market, and the trial was then continued with a 2-group parallel design. So in the middle of conducting their trial, they had to change their protocol. And the final analysis only compared patients who received hydrocortisone and fludrocortisone with those who did not, so the placebo group. So initially, we already know from this that initially the study was powered to do something completely different to what it ended up being. And that explains the difference in the title and the initial description. Now moving on to results. So they looked at 1,241 patients in the trial, and the 90-day mortality was 43% in the steroid group and 49.1% in the placebo group. And the p-value is 0.03, so we know that this is statistically significant. They then also calculated relative risk of death in the 2 steroid groups, in the steroid group, as well as the comparison to the placebo group, and that was 0.88 with a confidence interval of 0.78 to 0.99. So now we can be 95% confident that the relative risk of death is statistically significantly lower for the hydrocortisone and the fludrocortisone group compared to the placebo group alone. And then just kind of looking at the conclusions of the abstract, we can see that it was well, they've got their final kind of concluding sentence, which is just going to give us some information as to what they want us to think of the study. And finally, we know it was funded by the French Ministry of Health and Social Affairs. So that might give us some information about whether or not the trial was ethical. Cool. So once I've looked through the abstract, and this is just me kind of looking through, and I'll go through how I would summarize things and how I would answer questions later on. But this is just me kind of reading beforehand. So after the abstract, I would then move on to the demographic table. So this kind of describes the baseline characteristics of the patients. So just kind of looking at that, you can subjectively say whether or not there could be confounding factors in the baseline characteristics that they've shown us. So we can see that the sexes are evenly distributed, the ages are very similar, you can see that in the standard deviations and in the median, and we know that the site of infection is very similar. And really the only thing that I thought was kind of interesting here was that in the vasopressor administration, the dose of epinephrine or adrenaline that was received by the hydrocortisone plus fludrocortisone group had a very, very high standard deviation. So that just suggests that there was at least one significant outlier in this group who had a very, very high dose of adrenaline, a very high requirement of adrenaline. So that could potentially mean that there was one person in this group who was particularly unwell at the time. So that was really the only thing that I noted. So looking at that, I would think actually there was a very there's a very low risk of confounding factors, or there's no evidence of confounding bias in this baseline characteristics table. Then after that, I would move on back to methods, and this might not be something that you would like to do, but that's just the way that I like to critically appraise. And that's just because before I want to look at outcomes, I actually want to find out how they calculated those outcomes. So looking at the methods, just some things to note as we go through is that it was there was an independent ethics committee that approved this trial protocol. Then the participants were authorized by their next of kin. So that's also important for considerations of ethics. And they could provide written and informed consent before the inclusion, whenever it was possible. And that's particularly important for ICU patients because they're not going to be able to give their own informed consent. And then it was an investigators-led trial and it was publicly funded. That's also interesting for ethics. And then kind of moving on from here, if we look at kind of how they selected their patients. So their eligibility criteria, so they were included in the trial if they had indisputable or probable septic shock. Of course, probable septic shock doesn't sound great because I thought we were looking at people who are in septic shock for less than 24 hours. So that's also good because they looked at the kind of early effects of hydrocortisone and fludrocortisone on this patient population. And they also clearly define septic shock here. So they say septic shock was defined as the presence of clinical or microbially documented infection or sequential organ failure assessment score of 3 or 4 for each of the organ system. So that's also just quite interesting or good to know because septic shock is often something that is quite subjective, and even though the SOFA score might be quite a loose definition, it is at least a way to define septic shock. They also detail kind of more inclusion criteria here that are a bit more specific, so vasopressor doses and so on. But then another interesting part of the method section that I thought was that once the protein C was taken off the market, activated protein C was taken off the market, they had to change the exclusion criteria because the exclusion criteria that were only relevant for that drug had to be removed, and that's just to include more people in the trial. So that could potentially suggest that later on, as the trial went on, they might have had a slightly different study population as to the initial investigation, just because of this that exclusion criteria that were no longer used. So I think kind of after looking at methods, a quick scan through the methods, I would then be ready to kind of look at the trial outcomes. So this is a great table. This is something that you'll very commonly see in interviews, just because it gives you a lot of information, a very small bit of paper, so it's very easy to show you. But basically here we can first have a look at the primary outcome, always have a look at the primary outcome. So this was death from any cause at day 90. And we can see the placebo and the hydrocortisone group, and we can see the number of patients who died in each of them, and then the percentage of people. So that's the number in the brackets there. And obviously the relative risk. So that's going to be the percentage of people, or the number of people in the hydrocortisone group that died divided by the number of people in the placebo group that died within 90 days. And we can see here that the p-value is 0.03, that the confidence interval for the relative risk does not cross 1. So we know that this is statistically significant difference. And then kind of moving on to the other outcomes, we can see that they're all statistically significant based on the p-values, except for death from any cause at day 28, which has a p-value of 0.06. But that might just be because the study was not powered enough at that point in time. And also the decision to withhold or withdraw active treatment, which really did not show a significant difference at all. The relative risk significantly crosses 1, and the p-value is very high at 0.69. So that's just something interesting to know. And then looking at the kind of Kaplan-Meier curve here. So this is the probability of survival curve, also called Kaplan-Meier curve. And what you can do with these is you can do a log rank test, which will give you the p-value for that as well. And that's just to compare the entirety of the kind of the pattern at which people died over that 90-day period. So we know that from the start, really, it looks like the hydrocortisone and fludrocortisone group just had fewer deaths. And again, that's a statistically significant difference based on the log rank test. And then also looking at the serious adverse events, it's just interesting to know that the adverse events that they looked at, so the risk of gastroduodenal bleeding was not significantly higher, and the risk of superinfection was not significantly higher, but the risk of hyperglycemia was significantly higher in the steroid group than in the placebo group. And that's, I guess, a common side effect that we already know of, so potentially not something that is too surprising. I'm going to leave the discussion. I'm not going to go through that. And I think a lot of the time discussions can be really helpful to read, just to help you find out what the authors of the paper actually wanted you to look into and what they wanted you to think about. But obviously the discussion is not really going to be the most essential when you're trying to critically appraise a paper, just because it's sometimes going to guide you in the wrong direction. So I would always leave it last. I'm not going to go through it now, but it's definitely something that is worth reading when you do critically appraise papers. Right, so if I now had to kind of present this paper to my interviewer, I would say that this is a multi-center randomized control trial that was double-blinded with a 2x2 factorial design set in France, looking at the effect of hydrocortisone plus fludrocortisone compared to placebo on the 90-day mortality of adult ICU patients with septic shock. And that would be my PICO sentence. So I've gone through the population, the intervention, the comparator, the outcomes, or the primary outcome, and I've mentioned kind of the study design very, very briefly. And that should be everything that you want to say in your initial sentence. So then the next thing that I say in my presentation is always going to be the main outcome. So I would present, now I would present that in the trial, the 90-day mortality in the hydrocortisone plus fludrocortisone group was significantly lower than in the placebo group, with a p-value of 0.03%, 0.03. The 90-day mortality of the hydrocortisone group was 43% compared to 49.1% in the placebo group. And the relative risk of death was 0.88, with the 95% confidence interval not crossing 1, suggesting that it's also statistically significant. So then after going through the main outcomes, I then move on to strengths and weaknesses. So I think that the strengths of this study were that there was no evidence of confounding bias in the demographics, that it was double-blinded and it was randomized, so that reduces kind of selection bias, and again, it reduces confounding bias. Then the outcomes were very robust, so they were looking at a 90-day mortality rate, which reduces kind of recall bias and attrition bias. And I would also say that they looked at both kind of the potential benefits of the drug as well as serious adverse events, which were also appropriate to that medication because it was things that we know can be caused by steroids and things that we are actually worried about. And finally, I would also say in the strengths that the study appears to be ethically conducted with kind of consent and an independent ethic committee. Then going on to the weaknesses, I would say that a major weakness of the trial was that initially it was powered for a very, very different study design, which then had to be changed in the middle of the trial. They didn't conduct an intention to treat analysis, but instead they conducted a per protocol analysis. So they only looked at the patients who actually received the medication in the end, rather than the ones that were allocated to different groups, and that might have contributed to bias. And yeah, I think those are the main limitations that I can think of. And then finally, I would comment on validity. So to comment on validity, I think a lot of the time you also need to take into account other trials. So this is where the discussion is really, really useful, because when reading that discussion, you'll know that there's been loads of trials that have been conducted, and some of them have shown a statistically significant difference in mortality for people with steroids and septic shock, whereas others have not. So it's a very disputed area. But kind of despite that, we can comment on the internal validity first. So this study appears to be internally valid, and that's because there is no evidence of bias that springs out to me. And yeah, so I would say that that there is not a very big difference in the relative risk that was found, or there could potentially be a very, very low difference in the relative risk because the confidence interval goes to 0.99. But generally, I believe that the study has found the truth in that study population, so that there was actually a difference between mortality in those two groups. But then talking about external validity and how relevant it is to kind of the outside world, we need to think about the other randomized control trials and what actually the study population was. So when thinking about the fact that there was loads of different studies that have been conducted that have shown different results, potential reasons for that could be obviously study design, but also things like the population that was studied. And looking at the population here, it looks very heterogeneous. So, for example, the site of infection, there are loads of different sites of infection that could be causing septic shock, and these were all included in the study. The majority of them were actually lung. So it might be, for example, that steroids would be super helpful for people with septic shock caused by pneumonia, but it might not actually be useful for people with the urinary tract infections that cause or urosepsis. So that's just things to consider. So I think in terms of external validity, if I had to comment on that, I would say that because just naturally people with septic shock are going to be a very heterogeneous population anyway, this study would not change the way that I treated my patients with septic shock. And this is just a personal opinion. And that's because I'm not sure that for the entirety of the study population, the steroids would actually be helpful. And I'm not sure which patients I would target with steroids and which I wouldn't. And then I also think that the whole issue with the protocol and the potential confounding factors through the third drug that was introduced and then removed could have skewed the outcomes as well. So out of those reasons, this trial would not change my my clinical choices, but potentially meta-analysis or further randomized controlled trials that look at more specific parts of that septic shock population could change clinical practice. So that's kind of how I would go through this paper and how I would present it as well. Right, so going back to my presentation. So for your interview, the top tips that I can give you are that the first sentence should always be PICO. You need to be very concise with the things that you're saying. So, you know, my rambling at the end about external internal validity might not be what they're looking for during interview, but this is just me trying to explain my thinking. As well as kind of familiarize yourself with research, statistical terminology. So things like bias, look at lists about all the biases that exist, have a look at confidence interval and all potential outcomes they could give you and they could show you. And then also just make sure that you practice. So have a look at different study designs, maybe critically appraise, you know, a cohort study and critically appraise a randomized controlled trial and have a look at a meta-analysis. And then also just familiarize yourself with graphs and tables and the way that data might be presented to you. And at the end, always mention whether or not that study is going to affect your practice and whether or not it has external and internal validity. But try and do that in a very, very concise manner. And they are going to interrupt you if you do ramble on. So don't be too scared. These are some resources that I've got for you. So feel free to have a look at those in your own time. And yeah, are there any questions? And of course, we'd love some feedback.